Thank you very much, chairpersons, for a wonderful and very heart-touching introduction. I feel very happy here, and I extend my heartfelt thanks to the organizing committee of RSSTI Gujarat chapter, especially my friend Dr. Pratap Jetwani, Dr. Sanjeev Pathak, Dr. Rutul Goklani, Dr. Parag, and all involved into this. And I feel very happy when I am standing before the August gathering, where I can see the senior most physician of Vadodara state, Vadodara city, Dr. Prapul Chandra Rana. And another thing is that I happen to be from his college, the Savai Man Singh Medical College, Jaipur. So I am extremely thankful, sir. With that, after very thought-provoking lectures from Dr. Amit, Dr. Sanjay Agrawal, I am trying to bring you back to the clinical science. And the topic given to me is by Dr. Pratap, the scientific chair, diabetic peripheral neuropathy, how to diagnose in the clinics, which is very, very important. Dear friends, we all know that these are the chronic complications of diabetes, like to the brain, heart, extremities, nerves, kidneys, and macrovascular as well as microvascular. But you see in the brain, there is one more addition, that is the cognitive impairment and the mental dysfunction. So that is again very important. But today, I will touch upon only the peripheral neuropathies, diabetic peripheral neuropathy, which is one of the most common complications affecting nearly 50% of the adults with diabetes. And it is associated with substantial morbidity, including the pain, foot ulcers, and lower limb amputations. Certain patients present to us only at a stage when there is a stage of limb amputations. So, they are reported to be the most common, as I told you. And look at this picture. You cannot see this, but you can imagine. And the patient who really perceives this pain can only tell us what is happening to him. So, what is diabetic peripheral neuropathy? The presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after exclusion of the other causes. 70% of the diabetics will lose sensation in their feet. Peripheral sensory neuropathy is the leading factor in diabetic foot ulcerations. Approximately 25% of these diabetics will develop a foot ulcer. More than half of all foot ulcers will become infected, requiring hospitalization, and 1 in 5 will require an amputation. And after a major amputation, 30% of the patients will have their other limb amputated within 3 years. 5-year mortality rate after limb amputation is reported as high as 74% when compared to cancer. It is greater than colorectal, breast, and the prostatic cancer. So we can see the statistics, we can see the volume of the problem, and the most shocking is that 75% of the amputations are preventable. And it is we physicians, not the patients, we physicians who can take the lead in preventing the amputation of our patients. And the estimated annual cost to treat diabetes related chronic complication like DPN is 58 billion US dollars. It is in the US, because here we are poor in doing these calculations, and diabetic peripheral neuropathy is the most common type of the neuropathy. I'll take you through 2 cases, and where you will understand how the patient presents, what are the problems. Mr. AC, a 29-year-old man, young person with type 1 diabetes of 12-year duration, which complained of sudden onset of pain in both the legs and the feet. At the clinic, he described the pain as an excruciating, burning, squeezing sensation in his feet and legs, accompanied by cramp in his calf muscles. During the day, he is unable to wear shoes comfortably and experiences worsening pain when walking or bearing weight. At night, he is unable to tolerate the touch of even the blanket on his skin. So you can see the agony of the patient. He has become exhausted from the pain and lack of sleep, complains of frequent episodes of diarrhea and has lost more than 10% of his body weight over the preceding 3 months. Another case, 55-year-old male bartender married with 2 children, type 2 diabetes for 15 years duration, treated with metformin 1 gram twice daily, glycoside MR 60 milligram daily, compliant with diet, and patient is a vegan, weight is constant, moderate alcohol intake but occasionally excessive, cigarettes are 12 sticks per day, checks blood sugar every morning, average is 135, but the HbA1c is 8.5, it means the blood sugar level is not under control, and he has been referred by a GP. The reason for referral is burning pain in the sole of feet, especially at night when lying in bed. At times experience lancinating leg pain, paresthesia, tingling or pricking pin and needles and numbness of the toes, sleep interrupted because of the painful feet, felt depressed. And this case study presents a challenging clinical situation every day to us. When we start asking our patients, what is the status? And we examine the patient's feet, we come to know that how he is suffering with this diabetic peripheral neuropathy. On examination, his weight is 76. General examination revealed a middle-aged man with a ruddy complexion and spider nevi on his cheeks and nose. Appeared anxious and mildly depressed, blood pressure 135/90. Weak, regular but weak foot pulses and no bruit. Cardiovascular system examination unremarkable. Stress ECG limited because of the painful leg on the exercise. Central adiposity and tip of the liver is palpated. Feet healthy, but toenails showed evidence of onychoxic overgrowth or thickening of the nails, which is very, very common in these diabetic patients. And as the age increases, as age advances, they are not able to take care of their feet, and this condition occurs. Absent ankle reflexes, which is very important, and impaired sensation to soft touch, pin prick and vibration sense. Random sugar is 180. CBC and hematological parameters are normal. Renal function, including the electrolytes, are normal. Liver functions abnormal with moderately raised ALT, AST, GGT, and ALP. Lipid profile, HDL 0.8, millimole, LDL 1.8, HbA1c is 8.5. So again, the HbA1c is not under control. Thyroid stimulating hormone is normal, and vitamin B12 is 105, which is below the normal level. Now, diabetic complications and comorbidities, you can see that the background diabetic retinopathy, peripheral neuropathy, calf muscle claudication on walking more than 75 meters on the flat surface suggesting peripheral vascular disease, microalbuminuria, hypertension, hypercholesterolemia, moderately depressed and anxious. And the treatment to this patient is taking paracetamol 2 to 4 hourly because of the pain, aspirin, perindopril, simvastatin, metformin 1 gram twice daily, and glycoside MR 60 milligram per day. Now, how to approach to the diagnosis of diabetic peripheral neuropathy in the clinical setting? Medical history assess the symptoms of burning, shooting or electric-like pain. At times, we have to ask the patient the leading questions regarding this. There may be hyperalgesia, allodynia, paresthesia, numbness, poor balance and falls, which is again very frequent. Clinical examination, at least one test or small fiber function of the nerves, and that is the pin prick sensation, and thermal discrimination, hot or cold. So these two tests are for the small fiber function, and at least one test or large fiber function, that is the vibratory sensations, light touch sensation using 10 gram monofilament on dorsum of the great toe, proprioception and bilateral ankle reflexes. And these are the tests which can be done very commonly in day-to-day practice also. But then we have to look for the differential diagnosis also. Is this patient really suffering from diabetic peripheral neuropathy, or is there some other cause which we have to alleviate? Consider, exclude the alternative etiologies like the kidney diseases, uremic patient, thyroid dysfunction, alcohol use, vitamin deficiency, particularly B12, like in this patient also we had B12 deficiency, medications, chronic inflammatory, demyelinating, polyradiculopathy, amyloidosis, infections and inflammatory diseases. So they all you can find out from the history, clinical examination and on the investigations. So not only the diabetic peripheral neuropathy, there are other kind of neuropathies also in diabetic patients. They are the cranial neuropathy, autonomic neuropathy, and focal neuropathies, and neuropathy that can be triggered by many factors. But now I am taking only the diabetic peripheral neuropathy. These are the patterns of the nerve injury in diabetic neuropathy. Several different patterns of neuropathy they can present in individuals with diabetes. Of these, the most common is the distal symmetric polyneuropathy, that is known as the DSP. Now, peripheral nervous system and the alteration in diabetic neuropathy, how it takes place. The sensory neurons, they relay sensory information from their nerve terminals, which are located throughout the periphery, to the dorsal horn of the spinal cord. And cell bodies of these sensory neurons are located in the dorsal root ganglion. Cell bodies of motor neuron resides in the spinal cord, ventral horn, and transmit information from here to the periphery. So this is how it happens. And when talk of the diabetic neuropathy pathogenesis, it is a busy slide, but I'll tell you the crux. The hyperglycemia and the dyslipidemia. As Dr. Sanjay Agarwal is telling about the pre-diabetes and the complications, even without development of the diabetes, the complications happen. How these complications happen? Because there is a continuum, and because of the decrease in function or of the beta cells and decrease in the insulin levels, the diabetes, when clinically is diagnosed, we have to go back 10 years. So 5 to 6% of the beta cells get disturbed every year, and these complications start right at that time, and even in certain patients, they are already there at the time of diagnosis. So that is the reason that we look for these complications in type 2 diabetic patients at the time of diagnosis. And in type 1 diabetic patients, 5 years after diagnosis, or if the lady attains the puberty, if it is in a female. So hyperglycemia and dyslipidemia together with altered insulin signaling lead to several pathologic alterations in neurons, glia and vascular cells that can lead to nerve dysfunction and ultimately neuropathy, including DNA damage, endoplasmic reticulum stress, mitochondrial dysfunction, neurodegeneration, and loss of neurotrophic signaling, and can trigger macrophage activation. And both the central and the peripheral mechanisms, they contribute to the neuropathic pain in diabetic neuropathy. Now, what are the complications of diabetic peripheral neuropathy? Early tissue damage, glowing toes, callus, superficial ulceration, plantar ulceration, callus cells scraped away, revealing ulcers. And there are very senior people, they consider that if the doctor has not examined the feet of a diabetic patient, it means the doctor has not examined or not seen the patients. So you have to look, every time you have to look at the feet of the patient. Look for if there is any cut, if there is any change in the color, if there is loss of hair. And even if the patient says, no, no, my feet are all right, ask him to remove this shoe, remove the socks, and physically look, touch, and I'll tell you, this is how the neuropathy is screened. Evaluate feet at every interim physical examination. Screen annually. Screen for loss or decreased ankle reflexes, which is hardly a 2 second, 5 second job. Loss of or decreased perception of vibration in the great toe. Loss of or decreased sensitivity to 10-gram monofilament in the great toe, and not only in the great toe. So 2-minute foot examination is very, very important, and I think we can devote 2 minutes to every patient of ours. Examine the feet for ulcers, callus, blisters, maceration, skin breaks and infection. Examine the toenails. Identify nature of any foot deformity. Examine the shoe. Observe patient's ability to perform foot care and examination by observing them replace socks and shoes, and establish need for patient education. And we tell our patient that when you go to buy or purchase the shoe, please go in the evening, because it has been seen practically that by evening the shoe size that increases by half a number. Now this is test for sensory function by the biothiometer. The vibration perception threshold, which may be measured by biothiometer or 128 Hz tuning fork, and other methods also. This is the test of sensory function by biothiometer, used commonly to measure the vibration perception threshold. And lighter sensation may be assessed by these von Frey horsehair or the nylon monofilament, which we usually do. And these are the tests for the peripheral neuropathy in our clinic. Routinely, the biothiometer for the vibration and for the touch sensation, the monofilament 10-gram study we do, and we do annually to all our patients of diabetes. Now, clinician encountered barriers in assessing and treating the diabetic neuropathy, which is very, very important. If we do not diagnose the neuropathy, we will not think of treating it. So what is the problem? The problem is that there is a knowledge gap among clinicians regarding methods to diagnose subclinical disease, need for more widespread implementation. No disease modifying therapy, current symptomatic treatment often inadequate, non-neuropathic etiologies of the pain. So we have to look for this. What ADA 2024 recommend regarding the screening? People with diabetes should be assessed for diabetic peripheral neuropathy starting at diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1, and at least annually, and also in type 1 diabetic patients, female patients, and when they attain the puberty. Assess for the distal symmetric polyneuropathy, include a careful history and assessment of either temperature or pinprick sensation, that is for the small fiber, and vibration sensation for the large fiber functions. Patients with diabetes should have annual 10-gram monofilament testing to identify feet at risk for ulceration and amputations. And these other, like the orthostatic dizziness, syncope, I will not take in detail because they are for the diabetic autonomic neuropathy. What RSSDI recommends 2022, all patients with type 2 diabetes should assess for diabetic neuropathy at the time of initial diagnosis and annually. Diabetic neuropathy system score NSS and the neuropathy disability score in type 2 diabetic patient has been found to be useful resource in evaluating diabetic sensory motor polyneuropathy as an important bad too. You see that the diametrical effect of glucose levels on microvascular permeability of peripheral nerve in patients with type 2 diabetes with or without diabetic neuropathy, and it has been published in Diabetes 2023. Diametrical correlation between HbA1c levels, that is the control of diabetes, and parameters of peripheral nerve capillary permeability in patients with type 2 diabetes and without. And the results indicate that glucose control may have different effects on the peripheral nerve capillary permeability patients with type 2 diabetes with or without diabetic neuropathy. So, to conclude, I have only taken the diagnostic in the clinic, not touched about the management or the treatment. Diabetic neuropathy can profoundly affect the quality of life, causing pain, numbness, and functional impairment. Recent studies and advancement in research are offering new insights into the mechanism of diabetic neuropathy and are paving the way for more effective treatments, and the effective management of diabetic neuropathy requires a multifaceted approach. And before I extend a vote of thanks to all who are here, I would like to tell you one thing more. Diabetic neuropathy is not just about the loss of sensation, but the gradual erosion of one's quality of life. So if we cannot maintain the quality of life, if we cannot improve the quality of life of the patient, quantity of life nobody can change. This is my perception. I may be wrong, but if we can improve the quality of life of the person coming to us with problem, I think we can really help him. And with that, I invite you all for this 7th annual international conference of our innovative physician forum at Delhi. And Dr. Dheeraj Kapoor, our scientific chair and president of the forum, is here with me. It is on 5th and 6th July, Hotel Vivanta by Taj, Dwarka, Nai Delhi. So you all are invited. And with that, I extend a thank to everyone. Thank you very much.